So what exactly is neurofibromatosis? It is a genetically inherited autosomal dominant disorder, which means only one copy of affected gene is needed to develop the disorder. Individuals with this disease suffer nerve tissue tumors or neurofibromas. These tumors may be benign or may cause serious damage by growing and compressing nerves and other tissues and organs. This disorder affects all neural crest cells, swans, melanocytes, as well as endoneural fibroblasts. On a cellular level, these cell types proliferate excessively throughout the body, forming tumors resulting in disordered skin pigmentation, and the tumors may cause bumps under the skin, color spots, skeletal problems, pressure on the spinal nerve roots, and other neurological issues. So, here's a brief history of neurofibromatosis. Neurofibromatosis was first described in 1768 by Mark Akenside, and then in 1793 by William Golub Taunus van Taunu, then by Professor Robert William Smith of Dublin in 1849, and then later by Rudolf van Chau in 1863. But who gets the most recognition for the description of neurofibromatosis is actually a van Chau student by the name of Frederick Daniel von Recklinghausen. That's why you'll sometimes read that neurofibromatosis is referred to as von Recklinghausen disease. Von Recklinghausen was a German pathologist. He did detailed and extensive descriptions of neurofibromatosis through the autopsies of a 55-year-old female and a 49-year-old male. Through this description, he coined the phrase hermochromatosis. Van Recklinghausen is recognized as a distinguished histopathologist, as well as his contributions to strain methods, but more importantly, for his 1881 paper on neurofibromatosis. Neurofibromatosis is divided into two different genetic subgroups, NFB1 as well as NFB2. NFB1 is the most common of the neurofibromatosis strains, affecting 3 to 4,000 people in the United States. Although an individual is affected with this disorder, 30 to 50% of these mutations occur from a spontaneous mutation of unknown cause. Once the mutation has occurred, it can be passed down for 2 generations. NFB2 is an even more rare disease, affecting 1 in every 25,000 people. Of the 50% of the infected individuals inherited the disorder. The others were caused by a spontaneous genetic mutation of an unknown cause. Hallmark findings of NFB2 is slow-growing tumors on the 8th cranial nerve. These nerves have 2 branches, the acoustic and the vestibular. The characteristic tumors of NFB2 is called vestibular schwannomas because of the location and types of cells involved. As the tumors grow, they press against and can damage structures such as the cranial nerves and the brainstem, which can cause serious disability. Genetically, why does neurofibromatosis occur? The genes that affect NF1 is located on the long arm of chromosome 17. It codes for the protein called neurofibromin, otherwise known as the tumor suppressor protein. The suppressor is a regulator for RNA kinase pathway P21 oncoprotein. When it comes to NF2, even less is known of its gene linkage and products. However, the location is on the long arm of chromosome 22, spot 11.1 through 13.1. It codes for proteins. Symptoms. What symptoms do people with this disease show? And when does this disease begin? And how does disease progress? Diagnostic artery tests show whether the person has this disease, but the main thing is that symptoms are from physical disfiguration to pain to cognitive disability. Now, NFB1. To diagnose NF1, doctors look for 2 or more of the following: 6 or more light brown spots on the skin, called café spots, measuring no more than 5 millimeters in diameter in children and no more than 15 millimeters in diameter across adults and adolescents. 2 or more neurofibromatosis or plexofibromatosis or neurofibromatosis that involves many nerves. Freckling in the area of the armpit and groin. Abnormal development of the spine or the temple bone of the skull or the tibia. A parent or sibling or a child with NF1. Now, to diagnose NF2, a doctor looks for the following: bilateral vestibular schwannomas or a family history of NF2, parent, sibling, or another child, plus a unilateral vestibular schwannomas before the age of 30, or 2 types of the following: gallinomas, melanomas, schwannomas, or juvenile cortical cataracts. Many children with NF1 have larger than normal head circumferences and shorter than on average. They also have abnormal buildup of fluid in the brain, and it's possible to complicate the disorder. Headaches and epilepsy are more than likely in individuals with NF1 than the healthy population. Cardiovascular complications associated with NF1 include congenital heart defects, high blood pressure, and constricted, blocked, or damaged blood vessels. Children with NF1 may have poor language or visual spatial skills and perform less than well on academic achievement tests, including a measurement of reading, spelling, and math skills. Learning disabilities such as attention deficit hyperattention disorder are common with children with NF1. Unfortunately, there is no real treatments for neurofibromatosis. Most treatments would be symptomatic, such as the removal of the neurofibromas on the surface of the skin, or the treatment of cognitive disabilities such as ADHD. Treatments. There are no real treatments for neurofibromatosis type 1. An estimated 3 to 5% of tumors do become malignant, requiring aggressive treatment. Individuals considering surgery should be careful and weigh in the risks and benefits of all their options before determining the right treatment. Treatment for neurofibromas that have become malignant includes surgery, radiation, as well as chemotherapy. Surgery, radiation, chemotherapy may be used to control or reduce the size of optic nerve galleons when vision is threatened. Some bone malformations, such as sclerosis, can be corrected surgically. Treatments for other conditions of NF1 is for relieving and controlling symptoms. Headaches and seizures can be controlled with medication. Since children with NF1 have a higher risk of learning disabilities, they should undergo a detailed neurological exam before entering school. Let me reiterate, there is no treatment for this disease, so many treatments are symptomatic. So, why did I choose neurofibromatosis? What is the personal connection that I have to it? Technically, you can say, I guess, I have neurofibromatosis or I'm a carrier of it. My father has NFB1. He has the tumors all over his body. He's had that since puberty. And as we studied or talked about in the previous section of the video, once a person hits puberty, the growths do become more defined, more pronounced. The older you get, the more defined these tumors become. Um, Again, I've always had a fascination and an interest in this disease because of my father.
And because of the fact that, I do have a child and the possibility of passing this disease to her um, was there. And we talked to a genetic counselor about the possibilities of having testing for it, but we chose not to. And because in the end, we felt and we didn't want to put her mother through that or her. But the main issue was that having or being a carrier for this disease is a viable or very important part of my life because of the risk of myself later in life, the risk my daughter later in life, the risk of my future children as well. Um, but the main reason I've done this is because for the past few years now, my father has been battling cancer, and he's been battling cancer because the one, he had prostate cancer, and second is that some of the benign tumors on his body have started to become cancerous. And on November 20th, he's going into surgery to have a few of those, his neurofibromas removed. Um, he's doing well. He did beat the prostate cancer, but now we're dealing with this. And again, it's a very important part of my life. Again, I'm going to interview my father, and I'm hoping to have video of us at the hospital. Hopefully, I will be able to interview his doctor as well. But thank you very much.